we have talked about diabetic foot ulcers, now we need to look in general at leg ulcers. And one of the most common type of leg ulcers that we find are venous leg ulcers that make around 70% of all ulcers that we find in the lower leg. And the problem here is that even with proper care, it can take up to more than 200 days to heal these type of ulcers. So if we had to look at what our objective is when we are handling patients with lower limb ulcer, our biggest target should be reduction of healing time. If you manage to reduce healing time, you are managing costs, obviously less dressings, less hospitalization, less referrals. You are reducing the complexity because you don't have as much problems, for example, infections, and more importantly, you are allowing the patients to go back to their normal life, leading to a better health-related quality of life. So the priority for leg ulcer patients is to reduce healing time, to get them back to their life as quickly as possible. If we are not achieving that, then we have to make sure that we do what we talked about in the first section of evidence-based practice, challenge our status quo, making sure that we are managing these patients correctly. If we have to go briefly to the anatomy and physiology of leg ulcers, remember that we have the superficial veins, we have the deeper veins, and we have the connection in between with the perforating veins. One of the important parts for us for this section is the valve, which are situated in the veins. These valves are there to decrease the pressure within the veins themselves, but more importantly to avoid reflux in the veins. So again, remembering about the venous system, there are two pumps which are working here. The first is the heart, which pushes the arterial blood, which pushes the venous blood up as well, but more importantly is the calf muscle pump. Every time we move our foot, either with walking or with exercises, the calf muscle contracts and relaxes. When there is this contraction and relaxation, this presses on the veins, helps propel the blood up, open those valves which are in the veins. When it relaxes, the valves go back and close, not allowing reflux. This is in patients who do not have any disease. If we have patients with chronic venous insufficiency, there is valve malfunctions, which is usually acquired. Very rarely it is congenital, where we have weakening of the vein walls. For example, when we have the bulbing of the veins that causes issues for our patients. But one of the most common features is high pressure by patients who have repeated pregnancies, obese patients, but also patients who are standing up or sitting down for a long period of time. Also patients who have an ineffective calf muscle, either because they are bedbound or chairbound or have a disability, but also difficulties in the leg. For example, we have a rigid heel or a hallux rigidus, where the foot doesn't flex and therefore the calf muscle is not working properly. So as we said, these ulcers, venous leg ulcers, are one of the most common, making up to 70% of the lower limb ulcers. They are due to the high pressure that is caused by obesity, by repeated pregnancies, by other issues like past deep vein thrombosis, but also poor mobility. They always happen in the lower 1/3 of the limb. It happens because of valve incompetency, because of that reflex that is happening, and the leakage of the interstitial fluid. And there are a lot of clinical signs and symptoms that can be indicative of chronic venous insufficiency. One of the most used classification systems is the CM classification. So if we look at the clinical part of it, then we realize that some of the aspects, for example, from C1 to C4, which includes spider veins, varicose veins, edema, and changes in skin color, sometimes are associated with old age. This is a huge misconception. Remember that these are signs and symptoms of chronic venous insufficiency, although chronic venous insufficiency becomes more predominant the older that we get. But once we see patients who have got these spider veins, which is one of the first signs, we have to make sure that these patients are referred to a vascular surgeon to make further investigations and, if necessary, to have corrective management. There are a lot of signs and symptoms apart from what we've talked about. You can have skin which is crusty, skin which is dry. You can have things like what we call hemosiderin deposition, where we have staining of the skin because of the fluid that is coming out and the red blood cells which are leaking into the skin. Another which is called the lipodermatosclerosis, which is sometimes referred to as the inverted champagne bottle. So it is very important, look at your textbooks. We have all the examples of these skin changes. Make sure that you look at these skin changes, that when you have your patients, you look at their legs in a knowledgeable way to make sure that if there are any of these signs and symptoms, they are referred to the proper departments. So if a patient does have a venous leg ulcer, as any other type of ulcer, as any other type of disease, we can look at a standard of care. And the importance of the standard of care in VLU has been highlighted by the European Wound Management Association, where they are suggesting, like many other people suggest, that the two important components, apart from the management obviously of the patient, is compression systems and the proper dressings. Why is compression important for our patient, and how does a compression system work? The compression bandaging or hosiery, what they do is they press the interstitial fluid back inside the circulation, press also the vein walls towards each other, and will allow the valves to start working properly again. We know from a lot of evidence that with good compression there is not just healing, which is better, but also less recurrence. Remember that compression is something which is a treatment, and that treatment needs to have a prescription. We need to refer these patients to the vascular surgeons who will confirm the diagnosis, but can also be confirmed by simple tests like, for example, an APPI that we will refer to later on. However, again, there's a lot of misconceptions about compression therapy. Many people think that whatever we use, it is correct, but it isn't. The correct compression system needs to be multi-component and multi-layer and gives you the correct therapeutic pressure, which is considered to be 40 millimeters of mercury. More or less is out of the therapeutic bracket where we have the proper compression going on. There have been changes in evidence. Nowadays, there are suggested that it can be also 20 millimeters, especially in patients who have mixed arterial and venous. However, what is most important is that whatever compression system we are using includes both long stretch and short stretch bandages, because the long stretch and combination of long and short stretch means that the compression is working both when the patient is at rest and when they are walking. The compression is called graduated compression system because of what is called the Laplace law, because the compression at the ankle is 100%, so we have the 40 millimeters of mercury, and it gradually decreases as it goes up the lower limb. So as we said, compression is something that should be monitored. We should make sure that we are providing the proper amount of pressure. The suggested pressure for pure etiology venous leg ulcers is 40 millimeters of mercury. When we have mixed etiologies, then we use reduced down to 20 millimeters of mercury. If it is an ischemic ulcer, obviously we don't use any compression because we don't want to exclude any circulation going down to the lower limb. One of the easiest methods that we can use to know if there is any issues or not is what is called the ankle brachial pressure index, the ABPI, which is very easy to do. We take the blood pressure in the arm and the blood pressure in the lower limb on the side which is affected. Then we divide the systolic pressures and we come up with a number. So the value, the correct and proper value of somebody who doesn't have any problem should be 1, because the pressure in the arm and the pressure in the leg should be exactly the same. If we have an elevated result, for example 1.3, 1.4, this is usually because the patients are diabetics, they have arterial calcification, so when there is arterial calcification, we will get a false elevated. So in diabetic patients, rather than doing an ankle brachial index, we do a toe index, taking the blood pressure in the patient's toe. There are different ways and different suggestions. However, the most common recommendation is that 1 to around 1.2 is the normal range, 0.9 to down to 0.8 is a range where we can still use full compression. Anything between 0.79 and 0.6 means that we have mixed arterial and venous. Anything then less than 0.6, then we have severe arterial disease and no compression should be done. In the older days, compression used to be a 4-layer system. We used to apply first orthopedic wool, which is there to absorb the exudate and redistribute the pressure and put some padding there. Then we use crepe cotton bandages that starts smoothing out that orthopedic wool. Then we have an elastic extensible bandage, and on top of that a cohesive bandage with the last two providing us with the compression. However, the first thing, it takes quite a long time to apply these bandages. It is quite difficult to learn how to do the 4-layer bandages. Should it be spiral? Should it be figure of 8? It is quite uncomfortable for the patient. So what happens is, it takes us a long time to do these bandages. As soon as the patients go home, they will remove it because it is painful, it is cumbersome, they can't use their shoes. Nowadays we have systems which include 2-layer systems. There are different ones. There are ones which are 2 layers, but we have only a foam and a short stretch bandage on it. Other bandages will have both a short stretch and a long stretch bandage, and some of them also include an indicator system which shows us how much to stretch and how much to overlap. In the past year or so, we have been very fortunate as well that now we have a multi-layer bandaging system which isn't just one bandage and therefore easier to apply and more comfortable for the patients. Another system of compression is hosiery. These are medical grade stockings that do exert pressure on the lower limb of the patient. There are different tariffs. For example, if you look at the French tariffs, it has got 4 grades, while for the UK tariff we have a more simpler system which talks about 3 grades. So if we look at the British standard truck tariff, class 1 hosiery will be very light, between 14 and 17 millimeters of mercury. This is usually used either in the early stages of the disease, like when the patient has got spider veins or visible superficial veins, but also could be used when we are traveling and used in people who don't even have CVI but want to make sure that they are protected. The class 2 hosiery system will give us the medium pressure around 18 to 24. These are used for a long time in patients who have a healed ulcer. Once we stop using the graduated compression system, the multi-layer bandaging system, which should continue about 3 weeks after the ulcer is healed, we should ask the patients to continue using this hosiery for the rest of their life as a prevention for recurrence of these ulcers. However, these are also used in medium severity varicose veins as well. The class 3 hosieries will go up to 35 millimeters of mercury, can be used as primary treatment. However, the problem here is these are very tight, and in order to put them on the leg it is quite difficult, and if you look at evidence, many would suggest that the graduated compression by means of multi-layer and multi-component bandages gives us better results. One of the things to remember is that if these patients remove these hosieries when they go to bed, they need to apply the hosieries before they get out of bed to make sure that no edema has come into the leg itself. So apart from venous leg ulcers, another type of ulcer which is not as common as venous leg ulcers but gives problems and headaches to clinicians and patients quite a bit is ischemic ulcers. Ischemic ulcers happen when the arterial circulation to the lower limb is obstructed by certain diseases. Not enough arterial blood is going to the lower limb and will start causing issues and problems for our patients. One of the first signs that we can see and that patients usually complain of first to you is what is called intermittent claudication. So intermittent claudication is when patients are walking, they get cramps in their leg, they have to rest a bit, then the pain subsided and they continue walking. This happens because the amount of arterial blood which is going down is not sufficient. One of the things that you have to note when a patient comes to you with intermittent claudication is asking them how long does it take for the pain to start and how long does it take for the pain to subside. Because the shorter the time that the patient walks to get the pain, the longer the time that the patient needs to rest, means that the more progressive the disease is. In advanced ischemia, the patients can be at pain all the time. These ulcers can appear in areas of trauma, but because there is lack of circulation, many times, unfortunately, it starts off with discoloration of the toes, which leads to gangrene. When it happens in areas of trauma, these are round in shape with punched out appearance, and even if you look at the lower leg, there are signs and symptoms that the circulation is getting less. How do we evaluate it? Doing something like an ABPI alone at this point is not enough. There are different types of investigations that we need to refer the patients to the vascular department of our facility. A common way, one of the first things that we do is usually the transcutaneous oxygen, but we have other types of investigations. Very commonly a duplex ultrasound will be done, but also a magnetic resonance angiogram or a contrast angiography can be done as well. What is obviously very important for us is that if there is ischemia, we start the revascularization as quickly as possible whenever possible. So how can we differentiate between venous ulcers and arterial ulcers? Just by looking at them, sometimes already we can understand which is one and the other. So if we had to look at the location of a venous ulcers, these are usually around the medial malleolus, while with arterial ulcers, these are usually areas of traumas or the distal toes. When it comes to the appearance, venous ulcers are usually quite irregular and shallow and many times highly exudative. While with arterial ulcers, they can be gangrenous, for example, in the toes. If it happens in areas of trauma, the difference is that while the venous leg ulcers are very irregular in shape, arterial ulcers are round and punched out. Pain in venous leg ulcers is usually mild to moderate. They complain a lot of dull aching pain and heaviness in their lower limbs, and this can be sometimes elevated by means of elevating the lower limb. In arterial insufficiency, we talked already about intermittent claudication. In severe ischemia, the pain is usually very severe, and if the patient tries to walk or elevate their feet, that pain will become worse. The pulses in venous ulcers are usually normal, while the pulses in ischemia is obviously also being absent. The other thing is looking at the lower limb. In general, we talked about, for example, venous insufficiency, where we have hemosiderin deposition, we have lipodermatosclerosis. When it comes to arterial insufficiency, the patient's legs will be hairless, they will be shiny, the skin should be looks taut, and also look at the toenails, because usually the toenails should be yellowish and thickened. The management, as we said, obviously is totally different. In venous ulcers, we need to use graduated multi-component layer compression systems and making sure that we are using dressings that will reduce the matrix metalloproteinases. In arterial insufficiency, revascularization is the key. Obviously, no compression at all. Changing the lifestyle in both patients will help, but more so in ischemic ulcers, because the patients, they need to stop smoking, they need to change their diet. And when it comes to exercise, we have to make sure that the exercise is prescribed by people who know what you are doing. Even when it comes to what we talked about diabetic foot ulcers before, we shouldn't just tell the patient go out and exercise, but make sure that the person who is suggesting exercise knows exactly what they are suggesting. One thing we alluded to previously was these mixed arterial and venous leg ulcers, where we hold both the chronic venous insufficiency and ischemia. What we have to do here is, when possible, obviously, do the vascularization. If we have predominantly venous ulceration, then we need to use compression, but at a very reduced way, around 20 millimeters of mercury. Apart from venous ulcers and ischemic ulcers in the lower limb, there are a wide range of what we call atypical ulcers. We have a list of these atypical ulcers in your textbook. For example, the margarine ulcers, which is a very aggressive type of tumor that can appear in areas that had previously ulcer ulcerations, unfortunately quite common in burn scars. These are very aggressive ulcers and need to be treated appropriately. Another type of ulcer, which is not that common but we can find as well, is what is called the martorell ulcer, or referred to as the hypertensive ulcers. This appears in patients who don't have either CVI or ischemia, but they have high blood pressure. These are caused by that high blood pressure. These wounds are quite painful. These wounds usually appear irregular in shape and near the medial malleolus, like venous leg ulcers do. And that is why we have to check do a proper examination of the patients to rule out and understand which type of ulcer we have. The management of these ulcers is obviously management of the pain, because these are very painful ulcers, management of the hypertension, but also we can use a little bit of compression and doing management of the ulcer according to the wound bed preparation. Another not so common but not that uncommon problem is what is referred to as pyoderma gangrenosum. This is an inflammatory disease, and although we are including it in today's session, this is more when it comes to dermatology. These wounds appear very suddenly as a result of small pustules or small red bumps or blood blisters, and are quite painful and are very progressive very quickly. One of the telltale signs of pyoderma gangrenosum is that on the outside edges of the wound you have like a purplish discoloration, which is quite indicative of the pyoderma gangrenosum. There aren't any tests to be done, however there's a score which is called the Paracelsus, which will help you identify even more if it is a PG or not. PGs can happen as the ulcerative classic form, however they can appear in other places, for example even as peristomal pyoderma gangrenosum. Management of PG, because it's an inflammatory disease, we need to use topical and or corticosteroids, which are given systematically, but also management of the wound according to the wound bed.